Hello, a very warm welcome to this new edition of PCR webinars that will be focused on atrial, secondary, mitral, and tricuspid regurgitation. My name is Marta Sitges. I'm a cardiologist working in Spain, and the objectives of this webinar will be to understand the epidemiology and the clinical presentation of combined MR and TR in patients with atrial fibrillation, to learn about imaging techniques and parameters that we need to assess these conditions, and to learn how to manage these patients, when to treat AFib, when to treat TR and MR, or when both. For this purpose, we will have a fantastic team. I will be chairing the session together with the coordinator of the session, who is Marianna Adamo from Italy, an interventional cardiologist. And also in the team, we will have as the speakers, apart from Marianna Adamo, we will have Denisa Muraru, an imaging cardiologist from Italy, Philipp Lurz, interventional cardiologist from Germany, and also Tom de Potter, electrophysiologist from Belgium. So let's start with Marianna Adamo, please, setting up a little bit what's the problem we are facing. What do we have in this condition? Marianna, please.
Thanks. Thanks, Marta. Thanks also for accepting to chair this webinar. So I will provide in the next 5 minutes a brief overview on the problem on epidemiology and the clinical presentation of MR and TR as an atrial phenotype. So I would start with some epidemiological data in patients with chronic heart failure. In this registry, we analyze the prevalence of MR and or TRs, or as isolated or combined valvulopathies. As you can see, the prevalence is up to 20% in these patients, so very high, with a different distribution according to the ejection fraction, so a higher prevalence of isolated MR and combined MR and TR in patients with FREF, and a higher prevalence of isolated TR in patients with FPEF. But the problem here is that there is no stratification according to the valve phenotype, so no differentiation between atrial and ventricular phenotype. However, if we look at the baseline characteristics of this population, you can see that a history of AFib is high and higher in patients with isolated TR and combined MR and TR as compared to those with isolated MR. So this means that an atriogenic etiology is more frequent in presence of TR. If we look at registries, including patients undergoing transcatheter treatment, for example, the repair registry, as you can see here, the prevalence of atrial SMR is 18%. These are patients with severe MR undergoing Pascal implantation. The prevalence of AFib is 87% in patients with atrial MR, and 41% of patients have a severe concomitant TR. In the Euro-TR registry, including patients with severe TR undergoing tricuspid TR, atrial secondary TR has a prevalence of 31%, and almost all patients have AFib, 97% in those with an atrial phenotype. This is an interesting recent publication showing that in patients undergoing mitral TR, prevalence of TR of significant TR is high, especially in those patients with AFib. The probability of having a reduction in TR after mitral TR is lower in patients with AFib, and the tricuspid regurgitation and AFib are the two conditions related with a worse prognosis in these patients. As you know, we have new nomenclature, new definitions of atrial MR reported in recent guidelines with some criteria, mostly echocardiographic criteria, but also clinical criteria. So as you can see here, not only AFib, but also FPEF are clinical criteria to have a diagnosis of atrial SMR. I don't want to go into details because Denisa will show the parameters and the limitations of these parameters, but just to highlight that for tricuspid, we don't have specific guidelines, but we have this consensus document showing specific criteria also to define atrial TR, and we don't have guidelines because the evidence is less strong for tricuspid than for mitral. This is what we have to keep in mind in this webinar, so that atrial secondary regurgitation have two possible causes. AFib is the most frequent, but also in some patients we can have FPEF, and we have to consider this. And these two conditions can cause or contribute to AV regurgitation, but also AV regurgitation can contribute to the progression of the FPEF and atrial fibrillation. So a vicious circle that have to be interrupted, and we'll see how. This is the typical presentation of these patients, as we see in our clinical cases. So old females with heart failure symptoms and increased NT-proBNP levels in most of the cases, with a specific echocardiographic picture, as we'll see in the next presentation. Thank you for your attention.
Thank you, Marianna. Thank you very much. I think you set up the picture very well of patients that we face every day in our clinics and that are difficult to treat. But before going to the discussion, let's move to Denisa. Denisa, tell us about the challenges of diagnosis of these patients. Sometimes people say, what is atrial secondary regurgitation? Please help us. Denisa.
I will try. Thank you, Marta. Thank you very much for the kind invitation to participate in this webinar to discuss a little bit about the challenges and the difficulties in the diagnosis. So, as Marianna showed, there is a high index of suspicion whenever you have an elderly woman with atrial fibrillation and HFpEF. However, the imaging approach is absolutely essential to make the differential diagnosis between atrial, ventricular, and other subtypes of regurgitation. And we have a whole spectrum that can be used in complex patients, including right heart catheterization, TOE, CT, and CMR. However, most important elements for the differential diagnosis, I would like to underline, they come from a transthoracic echocardiography. So this needs to be both implemented with a transesophageal. Regarding the guidelines on atrial mitral regurgitation, there is clearly some indication on how to make the distinction between atrial and ventricular. However, as you can see highlighted in those boxes, there is significant overlap because dilation of the chamber of the left atrium of the left ventricle can be present in both. Dilation of the annulus can be present in both, together with atrial fibrillation. So indeed, sometimes in the real life, we have difficulties. Most elderly have some degree of left atrial dilation. It's not clear how large it should be so that it becomes the main driver of the regurgitation. We also know from other studies showing that atrial and ventricular types of regurgitation, they don't have different sizes of the atria. They more or less have the same volumes, but the point is to demonstrate that there is a disproportion between the dilation of the atria and the dilation of the ventricle. I think this is the most important, and we have a cutoff around 1.5 for the tricuspid atrial regurgitation, but for the mitral, it still has not been reported. So indeed, this is one element that needs to be documented to make the diagnosis of atrial secondary TR. But as you see there, apart from the dilation of the tricuspid annulus, many aspects need to be excluded. So atrial secondary TR is an exclusion criteria of other potential causes. And I would underline the importance of excluding tethering of the leaflets, because the tethering of the leaflets underlines the fact that there is RV dysfunction or a significant remodeling, and this is typical for ventricular. But again, here, I think we need to discuss also about how to assess the severity, because this is the main point when we indicate treatment for a patient with TR. So is the phenotype important when we have to decide whether this tricuspid regurgitation is severe or not? And my feeling is that we need to account for the phenotype, but currently there is no proof or no recommendation. As you know, in the guidelines, we have a single algorithm to treat all TR patients like in the same way, all phenotypes, irrespective of whether they have primary atrial or ventricular. And we have a set of measurements that we have to collect, even if sometimes they are conflicting. ERA does not match in severity with the regurgitant volume or with 3D vena contracta area. So sometimes it's a little bit confusing when we have to grade the tricuspid regurgitation, particularly in patients with atrial fibrillation. So atrial fibrillation adds in this complexity because the regurgitant orifice many times is elliptical and not rounded. And if you just measure in the 4-chamber view, you will underestimate the severity. It's also variable from cycle to cycle. And also the PISA assumptions are not functioning in a patient with atrial fibrillation. So indeed, many echocardiographers are tempted to assess qualitatively the tricuspid regurgitation, how big is the jet visually, or they measure it. However, this is wrong because can be misleading. So you usually have big jets when you have high velocities. If you have low velocities, you will have low jets, and this is already known by many years. Another important point I said, we need to account for the tethering of the leaflets, because if you have significant tethering and you apply the normal ERA uncorrected, you will underestimate the severity of TR. So the new recommendations are to use a corrected PISA for the patients with ventricular secondary TR. And the final message is that the truth and the outcome prediction lies indeed in assessing the severity of TR, but mostly in how the right ventricle is coping with this increase in the regurgitation. And so even if you have an atrial secondary TR that is considered generally to have a better outcome than the ventricular secondary TR, but if you have a very high regurgitant volume with a low forward stroke volume and a low cardiac output, then these patients are actually at worse outcome than a ventricular secondary TR with not so much regurgitation. So assessing and adjusting for the load and assessing the right ventricle will be essential. Thank you.
Thank you. Thank you very much, Denisa, for this fantastic overview. So let's discuss a little bit on what Marianna has also shown us and you. So Marianna, this is really a frequent patient that we face, many times females, as shown before. And we have this triad of HFpEF, heart failure with preserved ejection fraction, we have atrial fibrillation, and we have tricuspid and also mitral regurgitation. So which one should we treat? All of them? Or where should we start?
Yeah, that's an excellent point. As I have showed in the slide, there are these three components contributing to the progression of each other. So, of course, it's important to treat all of them if possible, considering that for FPEF, there is no demonstration that medical therapy will reduce TR grade or MRT grade, especially on the right side. So there is a demonstration on remodeling of the left side, but not on the right side. But of course, everybody will administrate SGLT2 inhibitors and MRA in this kind of patients if needed. Regarding AFib, it's a more complex scenario because it depends on the timing of intervention on AFib, and the choice between rhythm or rate control is a complex choice. It depends really on the patient. And of course, after treating these two conditions, we have to think about the valves.
And this comes the point of the challenging diagnosis and identification of what is really secondary to atrial dysfunction, as Denisa nicely explained. And for this, Denisa, you highlighted the importance of understanding the disproportionate dilatation of the atria as compared to the ventricle with the specific values now that we have available for the right chambers, not yet for the left, but they will come. And you also mentioned the importance of excluding other causes, including the presence of leaflet tethering. Can you further develop a little bit more on how do we assess this tethering? Because sometimes in advanced and very overlapped stages, even if the star was atrial, we can find tethering, but how we should assess that for the general audience?
Yes, that is an important point because tethering has an important impact also on the probability of repair and on the outcome in general, and also indication of device. We know that if you have significant tethering, these patients are not good candidates for annuloplasty. So tethering is quite neglected parameter, but I think it should be included in any report, echocardiographic report, together with the dimension of the annulus. Having said that, how to measure it? We have at least 3 ways. If you use 2-dimensional echocardiography, it can be measured either as a distance from the annulus, a coaptation distance more than 8, or as an area. So the area defined by the leaflet toward the annulus, it's like a sort of triangle. However, it is, since the valve is 3-dimensional, we need 3-dimensional echocardiography to be more accurate, and we can obtain the tethering volume. And the cutoffs are 2.5 milliliters, and if we want severe tethering, it's 3.5. However, since when you do the volume, you also take into account the annulus. If you have an enlarged annulus, also this will affect the tethering volume, right? And so there is not this clear separation between atrial secondary TR, no tethering. There is always a little bit of increased tethering, but not so large like in ventricle. And we have these orientative cutoffs to try to make the distinction. But don't expect that you will have 0 tethering in atrial secondary TR. This is one misconception.
Absolutely, thank you, Denisa. The other important thing that you pointed is quantification. For the general audience, I mean, usually our first attempt to quantify or semi-quantify, or at least integrate in our minds, is to look at the color Doppler flow into the atria. Okay, so we have this problem with this very large atria, and therefore we have low velocities, and usually we know that this leads to underestimation. So could we, as a very initial trick, imagine the same flow in a smaller atria, how we would consider that? So that would be something like not to underestimate so much these regurgitations. What do you think on this initial approach?
It would be good, but I'm afraid it's not that simple. So because it's not just the atria, but also the size of the jet itself, as I showed, this is governed by the momentum, and momentum is proportional to the velocity of the jet squared. It means that if you have a high velocity, like in patients with high blood pressure or high pulmonary pressure in the moment of the examination, you will have a very spectacular jet, even if the regurgitation can be moderate if you quantify it. And vice versa, if you have low velocity with a big regurgitant orifice, the jet will be relatively low. So I would strongly discourage the evaluation, the visual or the jet assessment, and we need to be more quantitative, and this has been largely said in all the guidelines and documents.
So this is a very important message. So don't trust color Doppler in big atrias. Okay, so that's a very important message for the audience. In this sense, you propose more quantitative methods, but you also mentioned limitations of the PISA method. Is it useful in these patients? Can we use it, or do we have to have some precautions with it?
We have to use it because at least EROA is the parameter that is supported by the most important evidence. But probably, depending on the phenotype, we need to contextualize. So it may be that some parameters are better in primary TR, for instance, especially if it's not holosystolic. Probably we need to look more not at the orifice, but at the regurgitant volume, because we know that an orifice measured in one single frame may overestimate the regurgitation in that case. Conversely, in a patient with a secondary mechanism, especially if you have a small ventricle, probably the regurgitant volume will not tell so much, but we need to look at the regurgitant fraction. And probably there is recent data showing that we need different cutoffs for atrial and ventricular, but this is still at the research point and we need more robust evidence.
Yeah, hopefully we will have more data on this still recently recognized entity, which is atrial secondary regurgitation. So what do you recommend if you still are struggling trying to do all these measurements and you still have doubts? What do you recommend our audience to do with these patients that you're not really sure if you should treat because of the severity of the regurgitation, or you are not sure that this is really atrial secondary regurgitation? What's your recommendation, Denisa?
First of all, we need to adopt specific parameters for each valve. So we cannot compare mitral with tricuspid. Tricuspid has a different geometry, and we need to adapt our tools to assess the tricuspid, and in one way we do the mitral. Second, we don't sometimes remember the fact that the patients are symptomatic during exercise. And so whenever there is a discordance between the severity at rest or is not clear and the patient is symptomatic, mitral, for instance, if you have a moderate severe, by quantitative measurements, the patient is symptomatic or the ventricle is mildly dilated, I would strongly recommend exercise echocardiography. And in doubtful cases, right heart catheterization may add important information, like, for instance, the presence of and severity of pulmonary hypertension. For sure, CMR is also recommended whenever we are in doubt about the chamber sizes, but still echocardiography remains the first choice modality, complementary TTE and TOE. But there is no single parameter, no magic wand to reply to this complex situation.
Absolutely. Thank you so much, Denisa. That was fantastic. So let's move to the next presentation that will be done by Philipp Lurz. I think you have a nice case to share with us for discussion, Philipp.
Thank you very much, and mostly thank you for having me in this wonderful webinar. Yes, we do have a case of a combined atrial, mitral, and tricuspid regurgitation. And as said before, these patients, they're often female, they're often elderly, and that's also true for our patient, a 78-year-old lady who was clearly symptomatic in NYHA class 3. She had also signs of right heart failure with peripheral edema. Her medical history included long-standing persistent atrial fibrillation. Overall, her conditions met the criteria for HFpEF. There was moderate to severe atrial functional mitral regurgitation. And there's also put into the report, there was massive atrial functional tricuspid regurgitation, no relevant coronary artery disease, clearly limited renal function with a GFR of 35, hypertension, diabetes, and severe obesity. So that patient was first seen by the general practitioner, who obviously noticed her signs of heart failure and then referred her further to us. So she was seen by an imaging. She underwent TEE, and in that image you can see that the left ventricle was preserved in terms of systolic function. Also, right ventricle, relatively good systolic longitudinal contraction, certainly some dilatation of the right ventricle, and both atria appear to be enlarged. If we then look a little bit closer towards the mitral valve, you can see that there is significant regurgitation. The ERA was measured to be 0.34, and this was considered to be functional mitral regurgitation, but atrial functional mitral regurgitation. As said, she has uncontrolled atrial fibrillation, and at the initial presentation, she was not very well controlled in terms of heart rate. That's if we then consult the guidelines once again, then we hear and should also adhere to that rhythm or rate control is something which normally comes first. And if you have a look at her medication, there was still the possibility to increase the beta blocker, and that was the first step in this instance. So we went for a rate control. Rhythm control was shortly discussed, but overall the impression was that long-standing sinus rhythm, the likelihood that that can be achieved was not very high. The increase in beta blocker was successful in that respect, that her rate was then much better controlled, as shown here. However, she was still symptomatic. She was remained in NYHA class 3. She remained to have right-sided heart failure symptoms despite medical optimization. And then it was time to discuss her in our heart valve clinic at a specialist heart valve center, and she was referred for interventional treatment. We now have a more detailed look at the very specific anatomy. As said, atrial functional mitral regurgitation, so almost no coaptation depth left of the leaflets. However, it is in such an extreme case where sometimes you can see hamstringing of the posterior leaflet. That's something which was not seen in this case. If we then go to the right side, again on TEE, including transgastric views, there was significant tricuspid regurgitation. It was graded 4 out of 5. You can appreciate on the transgastric views that the jet is mainly central or anteroseptal. The leaflet morphology represents a type 3B, meaning that there are 2 posterior leaflets, 1 anterior and 1 to 2 septal. That is also slightly a subjective approach to it, but there seem to be more than 1 leaflet. And although these images aren't the best with respect to appreciating the extent of the TR jet, it is probably much better appreciated on a transgastric view. Okay, we also added right heart cath, and that showed postcapillary pulmonary hypertension. We do have a pronounced V wave on wedge pressure, and we also see a quite pronounced V wave in the right atrium. So in both cases, hemodynamic expression of significant MR and TR. So I said that very briefly. When considering the likelihood of a potential successful repair in these cases for mitral atrial functional regurg, it is important to consider whether it's isolated annular dilatation or whether there's also some degree of hamstringing of the posterior leaflet due to severe atrial remodeling. This can be quite difficult to treat, but that was something which was not present in our case, and this is why we went forward, starting first with the mitral valve. This is an XTW device placed right in the center. What can be shown here is that the device is pulled up quite into at the level of the coaptation plane, just to make sure that as much leaflet is into the device, and by doing so, a nice tissue bridge was achieved, and you can see that that also resulted in a very good relief of the mitral regurgitation. There was almost no residual MR left. So we were quite pleased with that. We already initially said that because this lady is fragile and there is both significant MR and TR, and we did not expect TR to improve that much, even with a good result on the left side, we went on and also treated the atrial functional tricuspid regurgitation with 2 devices. Both devices were placed into the anteroseptal commissure. Can again appreciate on this transgastric view that the clip is orientated nicely, 90-degree orientation to the line of coaptation. That's the first device, and then the second device again went in anteroseptally. We had a good anatomic result, no distortion of the anatomy, which is also important, a bit of residual TR, but as we just have learned, sometimes after treating TR, the jet can increase in velocity, and that's also important when assessing the post-procedural result, and residual TR. A very thorough assessment showed that this is graded as mild, and that's the 3-month follow-ups. He was doing better, less symptoms, no peripheral edema anymore, very acceptable gradients across both valves, even an improvement in renal function, and as you can see, no relevant residual regurg, neither on the left nor on the right side. Thank you very much.
Thank you, Philipp. Fantastic case, straightforward, and a very nice demonstration of what we can achieve. But let me ask me something. Sometimes when we discuss, and Marianna, I want to comment, to hear your opinion here and to discuss with Philipp. Sometimes these patients, they say, oh, it will be futile if you treat these valves because the patient has HFpEF and atrial fibrillation. So, and Philipp nicely demonstrated that this can help, as you mentioned. No? So, what do you think, Marianna?
Yeah, that's an excellent point. You are right. There is a skepticism on this, but as we have already said, it's important to treat all the components of that vicious circle. And in this regards, I would like to ask to Philipp, in this specific case, how long did you wait after medical therapy optimization and of the heart failure and the AFib before treating the valves? Because this I think is an important point. Do we have to wait long, or can we treat these patients earlier, especially in a case like this?
I guess it depends a little bit on whether you go for a rate control or rhythm control. And after rate control, the effect must come early. But I would not expect that much degree of remodeling, especially not with the comorbidities. If you really achieve sinus rhythm, then you might want to wait a little bit longer to see remodeling. But remember, the patient was quite symptomatic, a lot of comorbidities. She was fragile, renal function was already down. You can wait a little bit, but I think it's very important that you make sure that you do not lose these patients during follow-up, and that because then is a certain risk that you come too late. And we waited here only a couple of weeks. She remained symptomatic, despite the fact that her heart rate came down, and then we made the decision also because the patient very much wanted that to treat her.
Okay. Excellent. The other question is, in this case, you treated both valves in the same procedure because the patient was fragile, as you nicely explained, and so on. And we know that in atrial MR and TR is less likely to have an improvement of TR after treatment of MR, especially in presence of AFib. But is this your approach in each patient with atrial MR and TR, or only in selected cases?
Yeah, a couple of things are important for me. First, and you said that already, is there a high likelihood that the right side will improve after fixing the problem on the left side? And it depends a little bit, obviously, on the success of your procedure, but also on the etiology. And in atrial functional MR combined with atrial functional TR, it is not very likely that the right side will improve dramatically even if you fix the left side. The other thing which is important, the complexity of the procedure. If you have a very complex procedure on the left, then I'm slightly more hesitant to do a combined procedure because the procedure then becomes too long. But you've seen this was a straightforward procedure overall. It took less than an hour to fix both problems, so that wasn't relevant. The other reason why I treat them, when I treat them at the same time, is when you fix the problem on the left side and then you pull back the guide to the right, when you have right to left shunting. I don't like to see that. Then I rather fix the problem on the right side, and then normally the right to left shunting goes away, rather than closing the hole with an ASD. You just fix the problem and then you don't have right to left shunting anymore. And then probably the most important reason to do it at the same time as a combined procedure, and that was the reason why we did it here, is in these fragile patients, it's just very convenient for them to have only one procedure, only once general anesthesia. And when it can be done successfully in a reasonable amount of time, then I think it's a very good option.
Thanks a lot. I mean, I fully agree with you. These kind of patients, the probability of having a reduction in TR is really low. Probably the main problem, in my view, is the reimbursement. Is the cost of the devices, probably. But this is not the topic. Okay. The other question is. If TR, for example, in some cases you can have, in many patients with atrial AV valve regurgitation, we have, for example, a moderate MR in presence of a severe or massive TR. In these patients, which kind of approach do you use? You treat only TR or treat or how do you manage these patients with moderate MR and severe TR? Can MR worsen after treatment of TR?
Yeah, very good question. But slightly complex clinical problems sometimes. I mean, obviously, you always start on the left side as long as both regurg severities are severe. But you specifically asked for moderate MR on the left side. And I think you can start fixing the problem on the right. But then once again, you have to make sure that you see these patients back, because as you said, very often you will then find the MR to increase. And one of the mechanisms might be that once you fix the problem on the right side, you increase forward flow to the lungs, you increase venous return to the left atrium, you have more filling on the left side, and that could also add to an increase in mitral regurgitation. So I think you can wait, you can prepare yourself then for a staged approach, but don't be too happy with fixing it on the right side, but make sure that you do a follow-up and check whether MR increased or not.
Nice. And regarding the device used, you use the TEER for both valves. When do you use replacement, for example, in atrial phenotypes? In this specific case, why did you use repair rather than replacement?
I always like to do repair when I'm absolutely certain that the outcome is very good. The limitation is that it's not always easy to predict, but in these slightly less complex anatomy, I think with all the learnings we made throughout the last years, we can predict it quite well. And then repair is great because you have just less things to worry about. Having said that, atrial MR, but also atrial TR can be extremely difficult to treat with TEER, especially when they come later, when there's almost a negative coaptation depth, when there is hamstringing, and in these cases, replacement is a great option. Hopefully on the left at a later stage, we don't have too many replacement devices approved there yet, but on the right, we do have some experience, a quite robust experience already with replacement with Evoke, and that's a very good option.
I have a last question, and then I will leave the floor to Marta. The guidelines actually indicate tier for atrial MR with a class 2B and surgery with a class 2A in combination with AFib ablation. And there is no differentiation, as we have said, between atrial and ventricular for tricuspid. How do you see these guidelines, and what is your future perspective in this field?
I do appreciate that recommendations in the guidelines very much. There is maybe a little bit more evidence on the surgical side of things. The problem is that these patients, as we have said, normally they're old, normally have a lot of comorbidities, and normally they have high surgical risk. So the guidelines with the recommendations is one thing, but the clinical reality is slightly different things. And even if we discuss these patients in the heart team, very often the decision is made that maybe interventional is a more straightforward approach given the high surgical risk. But however, having said that, all these patients should be discussed in the heart team. And overall, we need more data for atrial pathologies. We don't have the data, and we have to make sure that we not only treat these patients, but also increase the body of evidence here in this field.
Excellent. Marta, do you have other questions?
No, excellent. I was only to add one very small question. If waiting, after your first question, Marianna, was how much we should wait. Maybe, do you think waiting may worsen the anatomy amenable to be repaired of these valves, Philipp?
How long we should wait when we treat it in these combined?
I'm asking that if we wait more, the anatomy can get worse.
It's normally yes, that's an absolute relevant risk, and maybe we haven't stressed that enough, because the anatomy I've showed, that's a straightforward anatomy, but atrial MR and TR can be extremely challenging for treatment, also for surgical repair, by the way. But once you have these hamstringing, then it's too late. We have to avoid diagnosing patients or referring patients that late, that you have complete remodeling and a complete distortion of the anatomy, because then interventional therapy comes too late.
Okay, that was fantastic. Thanks for sharing the case. And we will move now with the electrophysiologist. Tom, what is an electrophysiologist has to say in this field? Teach us a little bit. I think you have another case to share with us to show novelties in atrial fibrillation ablation and how this can impact also on the valves. Please, Tom.
Thank you. It's indeed my pleasure to show not just what we can teach, but also what we can learn as electrophysiologists, because we do learn and observe quite a lot in the context of our treatment of atrial fibrillation. And what I want to explain in using the case that I will show you as a scaffold is that obviously we believe, and I'm sure we all do, is that there is this causal link between atrial fibrillation and valvular disease. It can cause tricuspid regurgitation and mitral regurgitation, and it's plausible, by physiologically speaking, it's plausible that this damage, this disease, can be reversed if, in the context of a AFib-induced regurgitation, you would be able to cure the atrial fibrillation. As we just heard from Philipp's case, I think in all of these cases, whether your primary target is the arrhythmia or the valvular disease, time matters. It will get worse. If you wait, it will get worse, and your window of opportunity will diminish. And obviously, I don't want to argue that treatment of atrial fibrillation is going to cure valvular disease. There is such a thing as persisting valvular disease, which will need action. But I do want to highlight the potential for treatment of arrhythmia and the link with underlying valvular disease, especially in the case of tricuspid regurgitation, is often overlooked. I mean, many of our patients have tricuspid regurgitation, and it's not often they're quantified, and it's not so often we really think there should be something done about this disease. So the case I want to show is a woman, 71 years old, no particular relevant history of disease or risk factors. And we actually have imaging from 5, 6 years ago when she visited for chest pain. And what you can see on the ultrasound is an enlarged left atrium with no substantial regurgitation at that time. Hang on, we're going a bit fast here. The clicker isn't doing what I want. There is, I would argue, as you see in this four-chamber image, at most a mild tricuspid regurgitation. We saw the patient again 5 years later, comes to the outpatient clinic for palpitations, and the echo remains unchanged, very mild tricuspid regurgitation, no other valvular disease, enlarged left atrium. And then 4 months later, she comes with a new symptom. As beyond the palpitations, she also develops dyspnea for 2 weeks ongoing. And at that point, persistent atrial fibrillation is documented. So it's not inconceivable, of course, that there was paroxysmal atrial fibrillation before, which has now evolved to persistent atrial fibrillation. And at this point, the ultrasound image does tell a different story. Now we can see there is some degree of mitral regurgitation. Most people, I believe, would argue, and we just heard we shouldn't look at Doppler images, but we're simply electrophysiologists. We look at Doppler images. Most people would argue probably not super severe mitral regurgitation, but clearly on the tricuspid valve, significant regurgitation. In the long axis view, you can see, and here on the four-chamber view, you can again see the mitral valve. You can already appreciate the tricuspid regurgitation in the window of the left, and here you see it more in focus, substantial tricuspid regurgitation, which is measured here with an ERO of 0.5 centimeters square, regurgitating volume of 21 cc's. This patient was scheduled for atrial fibrillation treatment for rhythm control, for PV isolation, in accordance with ESC guidelines, class 1 indication for treatment after failure of medical therapy, and based on ESTF, randomized study showing mortality benefit in early rhythm control strategies, and the ATTEST trial showing substantial benefit in, again, early treatment of atrial fibrillation, ideally before the evolution to persistent atrial fibrillation, ideally at the paroxysmal stage. But of course, we only made the diagnosis in this patient when she was already evolving to persistent, but very recent onset persistent. What we did in the patient is PV isolation, and what I want to share for 2 minutes with the audience is the way we do this nowadays. So the treatment strategy did not change. The treatment strategy has been PV isolation for more than 20 years. What did change substantially is the way we do this. We do this nowadays with pulsed field ablation, which is not a thermal ablation, which is not RF or cryo. It is electrical treatment of cells. It's called electroporation, which causes cell damage and has the unique benefit that there is no collateral damage to surrounding structures, no damage to the esophagus or the phrenic nerve, and also no fibrosis induced in the atrial myocardium, which has clear implications for the topic of this webinar. This is what it looks like, just to give you an idea. This is a PV potential, and the nice thing of being in the field of EP nowadays is we have this incredibly powerful single-shot devices, so we deliver the electrical pulse, and the PV potential is gone. It is typically a one-shot approach. This is what it looks like in the 3D mapping system. So a catheter is positioned in the pulmonary vein. We typically use 3D mapping and or intracardiac ultrasound. We put the catheter, deliver the pulse, and move on to the next vein. So this is what we did in our patient. This is not the image from our patient, by the way. This is an image from a live case to illustrate the concept. This is not our patient that I just showed you. But what did we observe in our patient? We observed at 3 months follow-up sinus rhythm 3 months after ablation, and a marked improvement in the patient's functional status. No more dyspnea. And on echo follow-up imaging, we can see that, again, the mitral regurgitation is no longer observed, and tricuspid regurgitation, while still present, is at best mild. There is mild tricuspid regurgitation remaining after ablation. So we did an analysis of our own in-house practice, let's say, for AFib ablation to check what the prevalence was of significant valvular disease. We did not do this for tricuspid regurgitation yet, but we did it for MR. and I want to share with you what we observed in our own data set. We analyzed 1,300 patients receiving ablation over a period of 2 years. And what this graph is meant to illustrate is that it's important to take home that currently we are not treating a lot of patients with significant valvular disease. What you see on the slide on the left is pre-ablation regurgitation. The pink patients are unknown data. So the light green patients are those patients with mild to maximally grade 1 regurgitation. You can see that they are by far the bulk of our patient population that is referred for AFib ablation. And you can see on the right, the post-ablation data set, that this proportion further increases, that the vast majority of our patients do not have significant regurgitation after ablation, that we only treat a very, very small amount of patients with severe mitral regurgitation at present. I don't want to defend the position here that AFib ablation should be first-line treatment for severe mitral regurgitation. That's not our practice, it's not what we observe, but I do want to defend the position that it is clearly possible for PV isolation to lead to regression of MR or TR. It is pathophysiologically plausible, and it is observed in cases as the case I have just shown you by underlying mechanisms, of course, of reverse atrial remodeling. As for the treatment of the valvular disease itself, timing is crucial. If you wait too long, there is no chance of curing the atrial fibrillation. And the energy source, the pulsed field ablation, as I showed you, may have a strong impact on atrial function, where with modern techniques, we expect far less atrial stiffness post-ablation. So that's the case I wanted to share with you. Thank you for your attention and happy to discuss.
Thank you. Thank you, Tom. Very illustrative case. So typically these patients come with atrial fibrillation. More than 90% of them have atrial fibrillation. But what are the indications? I mean, where is the limit? Is it the time of atrial fibrillation? Is it the size of the left atrium? What are the indications? Where are the cutoffs?
Well, this is an excellent question. I am extremely reluctant to say therapy is futile. As we also just heard in Philipp's discussion, futility is for me very, very, very hard to say. I don't have any hard cutoffs of saying this patient is unsuited for AFib ablation. Obviously, the parameters that make restoration of sinus freedom unlikely are duration of the atrial fibrillation. Long-standing years persistent atrial fibrillation is unlikely to be successfully treated with percutaneous catheter ablation, and risk factors such as atrial dilatation, typically in the context of valvular disease, risk factors such as obesity, risk factors such as other underlying disease. But I don't think it's possible to put this in flowcharts. The point I want to make is the reason we are looking at all of these cases and deciding as specialists, and if you take Philipp's case and if you take our case, I think we would have done exactly the same as Philipp did in his case. And I still think, looking at our case in retrospect, I think we did exactly what we needed to do for our case. I don't think you can make a flowchart for this. I think you need to look at the individual case, discuss in the heart team, discuss with the patient. This is what we can do. This is what you can expect. But if you ask me, do I have a cutoff, age cutoff, duration of a AFib cutoff, whatever cutoff, the answer is no.
Yeah, always difficult to make general cutoffs. I completely agree. But there are sometimes patients which are in moderate forms of everything, no? And sometimes we really need to break the circle. And sometimes to break the circle, you need to do both things. Do you see patients where we could do both things? Even maybe in the future we are doing concomitant procedures, who knows? How do you think the future will be? Or maybe near future?
I don't think we should say, we have not done concomitant cases, but it would absolutely not surprise me if some people have. I don't think it should be far future. It's not a far-fetched idea. You're there anyway. It makes sense. For us, what helps us in the diagnostic pathway, if we are looking again from my perspective as an EP, if we're looking at an AFib patient, in these moderate everything cases, we like to cardiovert them and see what happens and see what the impact of restoration of sinus rhythm is on the overall status of the patient and perhaps on the echo findings to understand the impact of the atrial fibrillation on everything else. If we think the atrial fibrillation is an epiphenomenon, most likely we will go for other treatment, maybe treat the valve, maybe offer rate control. If the cardioversion strongly influences us to believe that curing the atrial fibrillation will substantially improve the patient, we will go for that first. But as you indicated, I absolutely can see a role for concomitant pathways where atrial fibrillation and valvular disease is treated in one session.
Okay, and then my last question for you, Tom, is for us, it's important also to think how we do follow these patients. What about concomitant therapies? How do we follow it then? Because maybe they are still in sinus rhythm, but sometimes the valve regurgitation may recur. I mean, we should, how do we should follow up them?
Yeah, that's actually what I wanted to highlight also with my first slide. You're absolutely right that it's important to follow our patients. And I mean, it's rare to see a AFib patient, especially a patient with a little bit more long-standing history of AFib that does not have valvular disease. They pretty much all have some degree of valvular disease. And you're absolutely right that just curing the atrial fibrillation doesn't absolve you of saying that the patient does not need to come back to follow up. And in fact, we do. We see all of our patients back 3 months after the ablation, and then depending on their status, typically 9 months later, so 1 year after the ablation. Follow-up for us is ultrasound, is apart from the rhythm follow-up, of course, clinical follow-up is ultrasound.
Good. It's good to provide this message also to the electrophysiologist world. Like looking also at the valves is also important, and particularly as we have seen also on the right side, because as we know, this is sometimes concomitant mitral and tricuspid, but typically tricuspid, it's much more involved in this type of patients. Okay, so thank you, Tom. So thank you indeed. We are coming to the end of this webinar. I would like to conclude highlighting a little bit the triad, the clinical triad that Dr. Adamo showed us with HFpEF, atrial fibrillation, and valvular disease. In this case, atrial secondary MR and TR. It doesn't mean that we only need to focus on one of them. We need to treat all of them. And we learned today that we have new opportunities in the treatment of atrial fibrillation also, but of course on the transcatheter therapies of mitral and tricuspid regurgitation. But the most important thing, or a very important thing, is a good diagnosis, and I think Denisa Muraru made a fantastic review on how to identify these patients with mainly echocardiography, but with all the imaging tests that she mentioned. Try to phenotype these patients, identify these patients, and understand the limitations of quantification of valve tricuspid and mitral valve regurgitation in the specific situation of atrial secondary origin. We also learned that we have choices to treat these patients, even if they are high-risk patients for surgery, and we learned the typical presentation of these patients, female, elderly, many times with comorbidity. And also we learned on the potential of treating early atrial fibrillation, but not forgetting about these patients, even if they had received a successful atrial fibrillation ablation, they need to be followed up because regurgitation may come back and we need to treat it. So with that, I would like to thank you all for being with us. You will have this seminar again. You can rewatch it in PCR Live. It will be available in few hours. I would like to thank you all for being here, and particularly the speakers and the coordinator of this webinar, Marianna, for this fantastic hour. Thank you very much.